Hello, and welcome to Basics to Brilliance Haematology Podcast, the podcast series that will take your basic haematology knowledge up to a level needed to be an effective haematology registrar. We hope that the content we cover here will help you prepare for the dreaded Haematology FRC Path Part 1 examination. But most importantly, we hope that this series fills you with excitement for the fantastic, dynamic and highly rewarding specialty of haematology. My name is Dr. Anharad Everden, Haematology ST5 Registrar in the South West Deanery.
And my name's Dr. David Fazy, Haematology SHO, with aspirations to be a haemorrhage.
And let's get started on today's topic.
From basics
to brilliance. Hi David, so nice to see you again.
Hi Harry, we're back.
We're back.
Haemophilia ring.
Yeah, we are. Life got in the way for a little bit, but we're back on the recording.
as it tends to.
Yeah, exactly. So today we're going to do Haemophilia B, and we are also going to cover gene therapy. They're not strictly related. They're not strictly related topics in that the gene therapy can be done for both, but it is only licensed by NICE for Haemophilia B at the moment. So I thought it kind of tied in quite nicely as a topic.
Yes, lovely segue.
Yeah, great. Okay, perfect.
And this is us tidying up hemostasis.
It is, yeah, for haemophilia. And then we will carry on with further great things in clotting. But we're going to start.
There's so many great things.
There are so many. Oh, we've only scratched the surface. But we're also going to start our red cell series. So we're going to be even more busy recording even
more. The amount of
stuff.
text messages you've sent about it, I know you can't wait. I'm sure our listeners are also chomping at the bit.
Yeah. And we've got some great guest speakers lined up as well. So it's going to be good.
Wow. That's so good. So good.
Yeah. So let's start with an opening case for today. So we've got a young boy aged 1.5, and he fell over and has come in with a big swollen knee. On questioning the parents further and taking a bleeding history, the only significant thing was that spontaneous bruising was also noted in the history. When they looked back, they were like, oh yeah, actually there has been quite a lot of spontaneous bruising. Anyway, let's just say that there was no concerns about non-accidental injury. What else are you going to ask? So we'll leave the non-accidental injury stuff out for the time being because we've covered that on a different podcast.
Yeah. So we've got a decent history, haven't we?
Mm-hmm.
You know, there's a big hemarthrosis to a not particularly big stimulus. They're at the kind of the age that you would hope someone with a clotting disorder gets identified.
Yeah.
I suppose family history. Is there any family history of note there?
Very good. And what inheritance pattern are you suspecting?
I'm looking for an X-linked recessive.
No way. Very good. Okay, then what are you going to do next, lab test-wise?
So I would like to do a set of a clotting screen, a coagulation profile, please.
Yeah, okay.
And I'm expecting to see, because I'm primed with, could this be a haemophilia B, to see a prolonged APTT.
Okay, brilliant. So then what would you go on to do after that?
I would ask for a mixing study.
Very good.
And I hope in this scenario, unless you're being mean right from the outset, that it would correct with a mixing study.
Yeah, brilliant. So corrects with a mixing study, that's correct. And then we do a factor 9 assay.
Yeah. So we did a factor 8, but it came back normal. So we did a factor 9 because we're going for the super rare.
Yeah.
And I think I might be getting ahead of myself, but I think that it's the same as factor 8 in terms of severity score, isn't it? So severe is less than 1%, moderate's 1 to 5%, and mild is 5 to 40.
Yeah, brilliant, David. That's exactly right. Yeah. So this kid came back with a factor 9 of 1%.
Okay. In the severeness.
Yeah. So I guess moderate. I guess moderate, but borderline. Yes. And so was started on prophylactic factor replacement, which we'll talk about in a bit with haemophilia B. Good.
Would you do genetic testing then on carrier detection, or would you go? We've found the problem. Let's stop there.
In day-to-day life, I honestly don't know because I've actually not looked after anybody with haemophilia B, confession. And I don't know, therefore, what use it has clinically. It might have use in terms of if the mother is planning to have more children, to identify the mutation, to identify her as being a carrier or not.
Yeah.
So I think it would be useful in that sense, but I don't know if it's got that much use for haemophilia B in particular. Maybe it has benefit in predicting their risk of developing an inhibitor.
Okay.
I'm not sure. Okay, so then just an interesting twist to this case is that the young boy then came off prophylaxis aged 14 years old, because they found that the trough level of factor 9, I'm going to keep doing that all day today, factor 9 was 30, which is unexpected because obviously with prophylaxis we usually aim for a trough of between 1 and 3, like really not very high. Yeah. Have you ever, is this ringing any bells of anything you might have heard of before?
I mean, it sounds very loaded, but no, I haven't got anything.
So is this
You're going
very
to have to
cool,
enlighten me.
yeah, is this very cool phenomenon called Haemophilia B laden, which is basically where you have a mutation that reduces the amount of factor 9 that you're able to make. But when you go through puberty, then the androgens, the increase in androgens allows you to then express more factor 9. And so you often kind of grow out of this type of haemophilia B, which is kind of cool.
Wow.
Yeah. Anyway.
That is cool, actually.
Yeah.
Genetically fixing yourself with a bit of facial hair.
Yeah, exactly. So that's our opening case, just to get us thinking about how it might present and how we might want to investigate it.
Yeah.
And I would say, in general, with haemophilia B, because it's less common than haemophilia A, it's kind of like the kind of poor relative of haemophilia A in many ways. And it might be quite helpful because we do so much learning about haemophilia A. It's quite helpful to then do almost spot the difference, a giant spot the difference between haemophilia A and haemophilia B, because the presentation and the management is actually very similar for both, but there are significant differences that we need to be aware of. So, firstly, I guess the question is, how does haemophilia B cause bleeding?
A test so early. So it's this is when, I don't know, you're going to sort of curl up your toes as a proper hematologist, and I'm going to be like, oh dear. So it's part of the intrinsic pathway.
Yes, very good.
Which effectively is a contact activation of factor 12. Usually for when blood encounters a damaged vessel or something like that.
Yeah, okay.
So 12, 11, 9 is how I kind of remember it.
Yeah.
And then that does something with a 10A's complex, and then everything kicks off. Thrombin does its business.
Yeah, exactly.
that's me doing a bit of drudging.
No, that's good. That's really good, David. And I'm glad you brought it up in terms of the intrinsic pathway, because based on how we understand lab tests, it explains why the APTT is prolonged. And have I told you the way you remember the factors in the intrinsic pathway? Have I given you that before?
Have you got a good way of?
Well, it's just like it starts with 12, and then 12 ends in an E, so then it's E for 11, and then 11 ends with an N, so then it's N for 9, and then 9 ends in an E, so then it's 8, and then 10, and 10's in the middle because it's a big cross in the middle, where the intrinsic pathways combine.
That's going in the
It's
bank.
It's just an easy thing to remember what is otherwise quite difficult to remember. But I'm glad you brought it up in terms of intrinsic pathway, because you're right. It's 12, 11, 9, 8, and then 10. And so 9, activated 9, forms what you described as the 10A's complex, which is 10A, 9 and factor 8, all the activated versions, and they form this like giant raft, and then they make more clotting, and they basically work via 5 to make 2, which is prothrombin into thrombin 2A, which then converts fibrinogen into fibrin. So that's just a bit of revision. Great. But remember that is a very lab representation of clotting, so the extrinsic and the intrinsic being like completely separate pathways. And in real life, what happens is you have an initial production of thrombin via your extrinsic pathway, because that's where the tissue factor is released from actual vessel damage, for example. And so 7 and tissue factor goes to 10 and makes some initial thrombin. And then that initial thrombin then feeds back. It has a positive feedback loop on like 8 and 9. And basically then feeds into what we would otherwise describe as the separate intrinsic pathway. And it allows this big positive feedback and this propagation, which then makes this big thrombin burst. And that explains why in haemophilia A and B, you can't just upregulate your extrinsic pathway to be able to compensate for a lack of intrinsic pathway. It's the fact that actually extrinsic gets it started. It's like the initiation step, but then actually all of those intrinsic factors, will then like allow propagation and the thrombin burst, if that makes sense. So so that's why in haemophilia B,
it's an exponent, isn't it?
Exactly.
It gets bigger and bigger and bigger, and that's how the cycle. Yeah.
And so in haemophilia B, it's obviously factor 9 that is deficient, and so therefore that's why you don't get that proper thrombin burst, which is why you don't clot very well and it's not very stable. Good. Okay, brilliant. So that's just a bit of revision, really, and it's basically exactly the same as factor 8, so no difference to be spotted there. What about the gene? Can you tell me anything about the gene of factor 9 versus 8 and where it's found?
It's a small gene.
Yeah,
I know
that's
that.
right. Yeah,
and it's I've got F9. That's because I looked it up.
Yeah, exactly.
I wouldn't be able to drag that out of anywhere.
Yeah, so it's the factor 9 gene is smaller. It's still X-linked, but it's smaller than factor 8, which comes relevant later when we talk about gene therapy. And we get much more total gene deletions of factor 9 than we do of factor 8 because it's a smaller gene. And anything else you know about factor 9? How does it travel in the blood compared to factor 8?
So I know it's made in the liver.
Mm-hmm.
And does it travel in the plasma?
Yes, it does. And it doesn't need to be bound to anything. So do you remember factor 8 needs to be bound to von Willebrand factor to prolong its half-life and everything? Factor 9 can just casually float around on its own, which is why our initial test that we did in the clinical vignette at the beginning didn't involve us having to do any of that von Willebrand stuff that we do have to do when we're looking for a haemophilia A, to include that it's not a von Willebrand problem, but we don't have anything that binds to factor 9, so it's kind of more straightforward. And factor 9 has a longer half-life, which is great.
Oh, I was going to ask whether it was which way it went. I almost thought the von Willebrands would give it extra half-life.
But I think of it as that factor 8 is obviously a really unstable molecule. Well, not unstable, but I think of it as a less stable factor, and that's why it probably needs von Willebrand to help it, but it doesn't compensate. I'm sure there's no like scientific basis for that, but it helps me understand and remember.
Cerebrally.
Exactly. And I think you said where factor 9 is made. Where is factor 9 made?
In the liver.
Yeah, exactly. And it's made exclusively in the liver, which is another spot the difference between that and haemophilia A, because there is no releasable pool like there is in factor 8.
From endothelial bits.
Exactly. So how does that have clinical relevance?
DDAVP?
Exactly. So DDAVP is not an option for haemophilia B because there is no releasable pool that desmopressin can stimulate in haemophilia B. Okay, so we're only talking about factor replacement when we talk about treatment in haemophilia B. Good, but otherwise the investigations are the same for somebody you think might have haemophilia A and B. The presentation is also the same. Some people say that it's maybe slightly less severe bleeding phenotype than that of A, but honestly, I've never seen anybody with haemophilia B, and all the textbooks seem to suggest that they can present in exactly the same way. Severity, I think you've already touched on. So how do we decide on the severity in haemophilia B compared to A?
Will we do a factor study and then characterize them as we did?
Exactly. It's not a trick. I know you're like, what's she going to trick me with now? No, it's the severity is the same. So it's based on factor levels and it's the same cutoff. So severe less than 1%, moderate 1 to 5, mild 5 to 40. Sorry, I'm saying percentage. What I mean by percentage is IU, international units per DL, which kind of roughly equates in my head to a percentage. because like 100 is good for hemostasis, 1% is like bad for hemostasis, and it's just really helpful to think about it, and therefore as IU per DL, because you can kind of roughly equate it as a percentage in your head.
Yeah.
Cool. Okay, and so the use of prophylaxis is also the same for the same indications in haemophilia A and B. This is probably testing you a bit, but I'm going to ask you anyway because I always do. um, what are the indications for prophylaxis in haemophilia A? And do you remember, like, because they'll be the same as for haemophilia B? Do you remember?
Severe haemophilia.
Okay, yeah, very good.
And was it? It must have been. It was something to do with how many infusions they require in a certain period of time, which I can't remember.
So it was, I'm not sure it was how many infusions, but basically either severe, so less than 1%, or up to 4%. So it can be some of the more kind of severe moderates. And then anyone who's had an intracranial hemorrhage spontaneously. So those are your sort of three indications for starting prophylaxis. And again, we aim for a trough of 1 to 3% or 1 to 3 IU per DL. So we don't aim for a peak. We aim to maintain a trough at a minimum level. And we titrate to the symptoms and the lifestyle of the patient to prevent bleeds, which will be different for different people depending on what they do.
Yeah.
Okay, lovely. So then, shall we talk about factor replacement in haemophilia B?
Yeah. Yeah.
Do you know?
I don't know any. I was going to say I don't know any names. I was going to say the words recombinant factor 9, and then hopefully you were going to fix all those words for me.
Well, that's right, and that's a good point to make as well. Is that it is recombinant, so it's not carrying any viral risk. This is not plasma derived. Same as haemophilia A. We don't use any like plasma derived factor anymore because of the whole thing that happened with everyone, well, with a lot of people getting viruses. The main factor replacement in haemophilia B is called Benefix, which is quite a nice name. And
I like that.
It's a recombinant factor 9. And the big difference here is that the dosing is different. So the concept of dosing is the same. So you find out what their patient's baseline level is, or you take a historical trough if you don't have a level and you need to treat them urgently. And then you decide on where you want them to go up to. So let's say like 100 because they're having a significant bleed or an operation. But then do you remember before, how much did I'm being mean because I'm asking about stuff we did ages ago, but how much does your factor 8 level go up when you infuse 1 international unit per kilogram of, let's say, Advate, so recombinant factor 8? Do you remember?
I've got nothing.
That's fine.
I need to go listen to my own podcast.
Oh God, I literally could not listen to my own podcast. So it goes up by 2. So for every 1 international unit per kilogram, the factor 8 level goes up by 2 international units per DL. So therefore, do you remember we used to like find the difference? So let's say they were 50 and we want them to go up to 100. So the difference is 70. Then we divide that by 2, and then that would be the dose per kilogram for that patient. It's so much easier for factor 9. You don't even have to do the maths because 1 international unit per kilogram of recombinant factor 9 will increase your factor 9 levels in the blood by 1 international unit per DL.
Oh,
so it's a 1-to-1 ratio. Yeah, it is really dreamy. So you literally just have to find the difference between what the patient's factor level is now or was historically if it's an emergency and what you want it to be. And then you basically just dose that as IU per kilogram.
Oh, very nice.
Yeah, so I think that's really nice. So it's a nice little spot the difference there. And then we talked about the half-life of factor 9, which floats freely in the blood, unlike factor 8. And that why do we care about half-lives of recombinant factor?
Because then we have to give infusions less often, which is less likely to cause inhibitors.
Yeah, well, it's not that so much, but it's just the fact that if you need to maintain someone's factor level at a certain level post-op, for example. The shorter the half-life, the more often you're going to have to give the drug. That's why Nova 7 is a massive pain because the half-life's like 2 hours. So by the time you've given a dose, the poor nurse that's gone and got it from blood bank and given it to the patient, they're going back again to get more. So it can be really annoying. So basically the half-life of factor 9 is much longer than that of factor 8. So factor 8 was 8 to 12 hours, and factor 9 is about 18 hours. So that means that you can get away with giving prophylaxis every 3 days. As it's, we were doing it every day or every other day with the factor 8 for haemophilia A. So that's good. And then in addition, we have extended half-life products in haemophilia B, just in the same way that we did for haemophilia A. But the extended half-life of something that's already got a longer half-life is better.
Nice.
So there are two brands that I know of. There's Alprolix, which is a recombinant factor 9, which has got an FC fusion protein to it, so that does the antibody recycling.
Pegylation was the other one, wasn't it?
Yeah, pegylation, which actually I don't have an example for in haemophilia B, but also albumin bound as well to increase the half-life, and that was called Idelvion. I'm probably pronouncing that really badly. I've never prescribed it. No, don't ask me again. It's an albumin bound one. Thank you very much. But you can get away with the half-life of these products can be long enough that you can get away with prophylactic dosing with an extended half-life product once every 1 to 2 weeks. So that's big for the patient's quality of life.
Yeah, that's excellent, isn't it?
Yeah, I think in the trials for these extended half-life products, when they were given a weekly injection, 1 in 4 people had no bleeds. So not perfect, but you could get away with it basically. Cool. Okay, so what else do we need to cover? What about, before we talk about inhibitors in haemophilia B, what about just making sure that we're happy with emergency care then of somebody coming in with a bleed, like our young boy in A&E? And I don't know if you watch the UK HDCO videos, either live on a Friday or on the Path portal, David, or whether you're too busy doing IMT and on ICU. As I asked it, I was like, you're too busy doing IMT, aren't you? You don't have time
I'm too busy being humbled by
when you're a haematology registrar, you'll be able to do all of these nice things. You just got to get there. But basically, I love their videos. I think they're brilliant. And there's a new emergency care guideline, UK HCDO guideline, that's I think due to come out very soon in haemophilia. And one of the things that they banged on about a lot is the treat first principle, which I know we've talked about before. But I just thought it was really interesting because we're also doing a service evaluation of our care at the moment. And one of the themes that comes up a lot, I think, nationally is patients not getting the sense that the haematologists are involved early enough. And also people prioritizing investigations over treatment. So we know as haematologists, if someone with haemophilia B comes in having had a head injury, the first thing we're going to be doing is getting factor into that patient. But people outside of haematology are thinking, okay, let's get a CT head, let's rule out a bleed. And actually we should just be treating this first and not waiting for the investigations to confirm that there's a bleed in the brain. Because actually you're going to do the kind of overlying message was you're going to do very little harm by treating a bleed and getting the factor level up to a decent level, rather than waiting and then replacing it later. And personally I've kind of reflected on this as well and thought, okay, it's tempting sometimes in haematology when you're getting, especially if you've got a really busy on-call day, to just kind of field things over the phone because you're just being asked advice that you can give over the phone in terms of doses and this factor and that. But actually, I think going down and providing FaceTime to those patients to show them that you're involved in their care early on, I think is really valuable, actually. And I think sometimes patients get the impression that we're not involved very early, which sometimes we're not because we're not made aware, but sometimes we are, but they just don't realise that we were, if that makes sense.
Yeah.
And basically it's about just knowing that mild trauma can have more severe consequences than your kind of average non-haematology clinician might anticipate. And that basically don't wait for investigations. If there's a mechanism of injury you're worried about, just get on and give factor. And I think those are the main things. And they should be basically triaged and assessed within 15 minutes and then contacted. Haematology is supposed to be contacted straight away. and then treated within 30 minutes if you are worried about a significant bleed, even before you've got confirmatory investigations. So yeah, the treat first principle basically. And that's not a spot the difference, because that's the same for haemophilia A, B, and probably also things like severe von Willebrand's and stuff as well. Okay, what about inhibitors? Do you know about any inhibitors in haemophilia B?
Do they have names? Is this a thing? No, so just I guess
Do you think
neutralizing antibodies against factor 9, and then I guess the more you go into, the more you see recombinant factor 9 given, the more likely you are to identify epitopes that you're not happy with.
Yeah, exactly. So exactly the same principle as haemophilia A, you can develop alloantibodies to recombinant factor that you're given, especially if you have a complete gene deletion where you're basically not making any factor 9 because you've got
very foreign.
Haemophilia.
Yeah.
Exactly. Then you can make an alloantibody, which can be a real pain. But it's doubly a pain in haemophilia B, because not only can it cause increased bleeding and a lack of response to recombinant factor, which obviously is a problem, but also in haemophilia B, the inhibitor is like an immediate acting inhibitor rather than a time-dependent one. You know, when we talked about the properties of inhibitors on a like whole separate inhibitor podcast. So they're immediate acting, and often the antibody that you make against factor 9, if you have got haemophilia B, it can be an IgE antibody.
Ooh.
So
sounds
it can
anaphylactoid.
Exactly. So it can then bind mast cells and cause the mast cells to degranulate, release lots of histamine, etc., and mediate an anaphylactic response. So not only do they make you bleed more and make treatment really difficult, but also it makes factor replacement. Yeah, well, it makes factor replacement like genuinely dangerous.
Wow.
So that's why the first 20 exposures to recombinant factor 9 in haemophilia B must be given in a setting where there's a resus trolley for that reason. Because obviously, just like with haemophilia A, the earlier exposures are the highest risk. And as you go further on, I think after 150 doses in haemophilia B, if you haven't formed an inhibitor, you basically aren't going to. So yeah, they're a real problem. And so if you did find someone started getting a bit of an allergic reaction to their Benefix, you definitely want to be stopping and, screening for an inhibitor before they go on to then have like an anaphylactic reaction the next time. So that's definitely worth knowing. The only good news is that they're less common. In general, inhibitors are less common in haemophilia B. Only about 2 to 3%. As I think it was like 30% of severe patients in haemophilia A develop an inhibitor at some point. So quite a lot less common, which is good because they're quite a lot more of a pain. What treatments do you think we can give for somebody who's got haemophilia B with an inhibitor? So
do we have some bypass therapies?
Yeah, do we have some bypass? Fever? Would fever work?
I knew you were going to ask this, and I was trying to work out whether like emicizumab would work. But I was basically,
so, okay, let's break those down.
I'm not smart enough.
No, you can work it out with me together. So, fever. Fever is not going to work because it's a factor 8 bypassing inhibitor.
Yeah.
So, we can't use fever. The other one you said was emicizumab. So, emicizumab is a monoclonal antibody designed to bind your 9 to your 10 so that you don't need 8.
But we don't have 9.
But we don't have 9. So emicizumab, also not an option.
Also out. Yeah.
And actually there are no good antibody options. For him. Yeah, that's what I mean. It's the poor
You got
relative.
me. You got me.
It's the poor relative. Like haemophilia B does. This is why it has its own podcast. Well, it kind of does, but we're also lumping it together with gene therapy. So even we're guilty of the same crime.
It is called Christmas factor, though. That's the only thing. I was gutted to find out it was named after a guy called Stephen Christmas, not Santa Claus. Oh, I was like,
oh, David. It always comes up in our Haematology Christmas quiz, obviously.
Okay.
Yeah, it's perfect. It's designed for that. Yeah. It's basically the only one I ever get right.
Fun guys.
We are so much fun. We're the coolest guy. But yeah, so basically your only treatment option is Nova 7 for somebody who has an inhibitor.
Okay.
And what is the problem with Nova 7?
Um,
Well, there's a couple of problems, but it's the half-life.
the half-life. Yeah,
Yeah,
that's what you just mentioned earlier, wasn't
I
it?
did, yeah.
The
Yeah.
nurses dislike you. That's the
Yeah.
big problem.
I think in some places you can set up an infusion, so you can do a bolus and then
Okay.
an infusion for that reason. But yeah, it's a pain. I mean, who wants an infusion of factor going in? Do you know what I mean? That's
No. Yeah,
attached to
yeah.
something. So, and also the other thing about Nova 7, which is annoying, is it's just a fixed dose based on your weight. So I think if you've got a bleed, it's 270 micrograms per kilogram as like a single dose. Pre-surgery, I think it's 90 micrograms per kilogram as a bolus, and then every 2 hours you have to give 90 micrograms per kilogram. So you can't titrate it to a level. Because do you remember we had Obazor as another option for patients who have an inhibitor in haemophilia A, which is your pig factor 8, which if your antibody doesn't cross-react to pig factor 8, then
Yeah.
you can use the Obazor to treat the patient with an inhibitor. And the lovely thing about Obazor is that you can titrate the level and you can measure how much pig factor 8 you're giving the patient. So you don't overshoot and you don't cause a clot or whatever. As with Nova 7, it's just the dose. The dose
So
is,
there's no like
there's nothing to measure.
nonazole. No one's
No,
gone for the
no, there's
haemophilia.
no porcine equivalent. No, there's no
Oh,
porcine factor 9. There's no special monoclonal antibody like emicizumab for haemophilia B. It's sad, isn't it?
it's rough, rough.
I know. But luckily, the inhibitors are much less common, which is probably why
Yeah,
there
yeah.
hasn't been as much research.
Christmas factor's rarer. The inhibitors are rarer.
Yeah,
Ipso facto,
yeah.
no money.
There is an antibody called concizumab, which is an antibody against the TFPI, so the tissue factor pathway inhibitor, which basically effectively increases the amount of 10A that you have. And there's these trials called the Explorer trials. So I think the Explorer 4 trial was a proof of concept that it can be used in A and B. So instead of kind of tackling the underlying clotting deficiency, it just kind of increases clotting more generally by increasing 10 through preventing its destruction.
Well, I thought wasn't the tissue factor well?
Yeah.
Isn't it like a negative predictor in DIC if
I
it's
don't
really
know.
high?
I don't
Uh,
know. It sounds like you know more about that than me. But the
I
concern
might be
about
wrong.
these sort
I
of
might be
like
wrong.
kind of
Yeah,
agents where we're just kind of blindly increasing something like 10A is like, could it cause increased clots? And
yeah,
some of the I think the Explorer 7 trial showed that it was effective, the conusizumab, at reducing bleeding in both haemophilia A and haemophilia B, compared to prophylactic factor replacement, which is interesting. But they did have 3 non-fatal VTEs in the treatment arm with the conusizumab, but they were
yeah.
non-fatal and like who knows. But yeah, that's the concern about those. They haven't really taken off, or not yet anyway. But yeah, what about immune tolerance induction? Because that was a big thing we did in haemophilia A.
Um, I guess it's a thing, but I'm
You
also
fancy doing that on
concerned.
someone who's having anaphylaxis though?
Yeah, I was
Yeah.
gonna say, in many ways, if it's rarer as well, it's probably got
Mm,
less demand for it, which means there are less
mm.
centers that do it.
Yeah. We don't tend to do immune tolerance induction haemophilia B because if you remember with immune tolerance induction, you basically have to like give escalating doses of
Mm,
factor and tolerate the antibody peaking and then coming down, which peaking just because of causing bleeding, not a problem, especially when you've got things like emicizumab in haemophilia A to prevent bleeding. But in haemophilia B, you've not got anything to prevent bleeding apart from Nova 7, and they can be allergic to it. And have anaphylaxis. It can also cause nephrotic syndrome as well. So we don't do it basically, and rates of success are low. So we don't do that. So yeah, sorry, I don't mean to finish on a bit of a doom and gloom about haemophilia B. It's less common. Inhibitors in the disease are less common. Um, and then should we talk about gene therapy then?
Yes, the light at the end of the tunnel for
Yeah,
haemophilia
exactly.
B.
So gene therapy, what do you know about gene therapy? Do you know how we do it?
So, from what I understand, you take an adenovirus, you
Mhm.
scoop out all the nasty replicative and badness,
Yeah.
you hijack it by putting in a factor 9 DNA, and then you send it off into the body via an infusion. It makes
Yeah.
its way to the hepatocytes, into the nucleus, and then starts making factor 9 for itself.
Yeah, brilliant. Exactly. And we use an adeno-associated virus, as you say, and basically take out all the viral DNA and then stick in our vector DNA. Kind of important things to say is that it forms what's called a non-integrated episome. So that means that although the DNA that we want to introduce, the gene for factor 9, goes into the nucleus, it doesn't get integrated into the main DNA
Yeah.
of a hepatocyte.
So it's not like a retrovirus like a HIV or anything like that.
Exactly. And so the benefit of that is it reduces our risk of causing cancer, because one of the risks with gene therapy, which to be honest, we don't know the long-term effects of yet, is that it could potentially increase the risk of cancer. There are examples of gene therapy being used for some very rare diseases, which I can't remember what they're even called, where they did associate possibly the use of viral transferred genes could well have caused cancer in these patients down the line. And it's something that when I was on I know I'm getting into red cell now, but when I was on my red cell placement recently and they were talking to children about potential gene therapy, it's one of the things that is quite difficult to counsel people against, because you basically have to say there is a potential risk that you might develop cancer from gene therapy. We just don't have a long-term follow-up data yet. It's still quite new.
Yeah.
But yeah, the idea of not integrating into main DNA potentially reduces the risk of cancer. Disadvantage, though, is what? What do you think would be the disadvantage of not being able to integrate the new factor 9 gene into the main DNA?
So I guess they're non-dividing cells, aren't they? So once the cell dies, it's gone. You don't sort of get additional hepatocytes that replicate.
Yeah, so hepatocytes do replicate. They've got an amazing ability to grow. Like there's that thing where you can transplant like a tiny liver and they grow a whole new liver, right? And as you grow in size from being a child to an adult, your liver grows with the size of your body. But if you did, let's say, gene therapy in a child with severe haemophilia B, they wouldn't be able to pass on that new gene in that hepatocyte being infected, because it's not part of the main DNA when they undergo, mitosis. It's a separate bit of DNA, so it wouldn't get passed on. So potentially it means that the number of hepatocytes that you have that can express factor 9 will reduce as you grow, like it will get diluted down. So that's a disadvantage, especially when we're thinking about doing gene therapy in children.
Can you not just re-inoculate them at certain points in their time?
So far, no, that's not that hasn't been done yet.
Okay.
I think maybe the concern with that is, what if you end up getting too much expression of the 9, which then causes clots, which also is a risk with gene therapy, even with one infusion in some patients.
I guess it's a very difficult dose curve, isn't it?
Yeah, exactly. And it's difficult to know and is different in each patient as to what level of factor 9 you achieve. Okay. So just to take you through the history of it to understand that a bit more. So when they first did the first gene therapy studies in haemophilia B, they found that in the first initially they got like a rise in the factor 9 production, and then it plateaued and then it went down. And it went down around the same time as the ALT went up. So they had a peak in factor 9 at 2 weeks, and then at 4 weeks the ALT peaked. And then once the ALT had peaked, that factor 9 dropped down quite steeply. And so they were like, hang on a minute, it's almost like there's...
Sorry, Harry, can I stop you? I've lost sound.
So I think something that's really helpful in understanding gene therapy in haemophilia B is just going through the history of how we got to where we are now. When they first did the first studies of gene therapy in haemophilia B, we found that the factor 9 level peaked after the infusion at about 2 weeks. And then sharply after that, at about 4 weeks, there was quite a significant rise in ALT. And then once that rise in ALT occurred and it peaked and went down, the factor 9 then disappeared quite quickly. And so it was a bit disappointing. And people were like, hang on a minute, it seems like there's loads of inflammation going on in the liver. And it's probably that the immune cells are going in, recognizing infected hepatocytes and killing them off.
Mm-hmm.
So then there was the St. Jude study, which I think was essentially a study that first introduced the use of steroids post-infusion to reduce that inflammation in the liver. and basically at the time of the ALT rise, they'd give a good dose of steroid, and they found that really helped. But then the big breakthrough, which was very cool, was discovered in Italy. Do you know where in Italy, or have you heard of what I'm talking about?
No, am I going to embarrass myself here?
It looks
No,
nice
no,
on
I haven't.
pictures. I've never been, but a place called Padua.
Okay.
And Padua, basically, there was a Italian family there that were found to have lots of VTEs. And when they were looked at, they were found that their factor 9 levels were extraordinarily high. So they isolated the gene, which basically makes too much factor 9. And they were like, what if we put this gene into hepatocytes to compensate for the fact that so far we're not getting great factor 9 levels? So they called it the Padua construct. And that's now the gene that we introduce in gene therapy, which is quite cool. I think that's quite nice.
I like that. Yeah, not so good for that family, but
No.
for the rest of us, it's.
But it's the first genuine use of thrombophilia testing.
Yeah.
Because genetic thrombophilia testing is the bane of our life. Everyone asks for it on calls all the time, and it doesn't change management 99% of the time. But this thrombophilia testing has actually led to a really cool breakthrough. So I think that's quite nice. And so then it was the main study was the phase 3 trial was called HOPE-3, published in the New England Journal of Medicine in 2023. And basically it showed that you got a variable expression of factor 9, but it was effective and it was a good duration, different in different people, but that the annualized bleeding rate in the gene therapy arm was better than that of using prophylactic Benefix, which I thought was a really good comparator. Because do you remember in those emicizumab trials in Haemophilia A, they compared use of emicizumab against as required, no prophylaxis, which is a totally unfair control arm designed by the drug companies. But with this HOPE-3 study, it was gene therapy versus regular Benefix prophylaxis, and the gene therapy group did better in terms of the bleeding rate, which I think is really cool.
What kind of factor level would you expect to see in a person that goes from, say, severe to having their mutated F9 put in?
It's really variable. Let me just see if I have an answer to that.
I've been dug in.
I'm trying to see if I have anything in my notes. I have not written it down.
Ignore me. We'll go back and get rid of that bit.
Okay, sorry. No, but actually, I think
right.
it's a relevant question, though, David. Hang on, I'm going to pause the thing.
And of those people that had the special F9 gene implanted, what was the factor 9 activity brought up to?
Yeah, it's a good question. Looking at the HOPE-B study, it looks like the mean factor 9 activity that was stable and sustained was about, I think they said, I'm just looking at it now, 36.7%. So
that's decent.
Yeah.
You're almost out of mild, aren't you?
Yeah, exactly. So a 30-ish IU per DL kind of level. So that's not bad, but it's not normal.
No.
But I guess it's sort of equivalent to when we think about emicizumab in a way. Yeah. So that was, I think, very cool and a really good study, the HOPE-B study. In terms of eligibility criteria in the NHS, what does this actually mean in terms of what we can give people? It's quite a strict eligibility.
I bet.
And it's not allowed in Haemophilia A at the moment. The reasons that it's not as successful in Haemophilia A at the moment is because Haemophilia B, well, you tell me, what do you think are some of the reasons?
So I guess it's a small gene, which makes it easy.
Yeah, factor 9 is a much smaller gene. Yeah, it's easier to package into a virus.
Do you need less yield from the gene to get a better outcome, as opposed to factor 8 needing a decent amount of factor 8 to get a reasonable
I don't think so, because we're talking about IU per DL for both.
I suppose.
It's also the fact that we found this Padua construct, which was a big breakthrough factor 9.
Is that carrying a lot?
Well, it is, because it results in you making 8 times more factor 9 than you would normally make. So that really compensates for loss from viral infection. And also, I guess, remember what we were saying before with our spot the difference in haemophilia B. Factor 9 is made in the liver anyway. Like it's a normal
So
thing to be
hepatocytes,
made.
yeah.
As like
Easy
the
to
factor 8
target
is
with
made in
an
other places.
adenovirus.
Yeah, exactly. So it's not like you're forcing a completely extra role on a hepatocyte, which you are
Yeah,
doing in haemophilia A, and they think that leads to increased stress on the hepatocyte in
yeah.
terms of like protein production and, hijacking the ribosomes and stuff to make this new factor. So yeah, so it's only licensed on by NICE at the moment for haemophilia B, but you have to have a factor 9 level of less than or equal to 2%. You
Okay.
can't have had a current or past inhibitor in
Oofed.
haemophilia B. I know. And you're not allowed to have any severe liver disease for obvious reasons because you're going to get
Yeah.
liver ALT rise. You also, interestingly, cannot have high level antibodies to the adenovirus, the AAV5 vector virus that we use for the gene therapy, because they
Yeah.
showed that people who had pre existing high levels of antibody just basically cleared the virus. It didn't work. So that's just a waste of money. But yeah, if you meet those criteria, so you've not got too high antibodies, your liver's all right, you've not had any inhibitors in the past, and you've got severe haemophilia B, then you are eligible. And they estimate about 250 people in the UK are eligible for gene therapy for haemophilia B. And yeah, once your factor 9 levels are above 5%, they say you can then stop your prophylaxis if you're on prophylaxis. And the levels generally stabilize like 6 to 12 months post infusion.
So are they giving these to children?
Yes, you can. You can give them to children. I don't think there's an age cutoff.
So can this be given to children?
Actually, I don't think it can be because the Hope B study was in adults, male adults. So I don't think they have the evidence for it. And I think it's that whole
Little liver problem.
exactly. The fact that it's not going to be passed on to your growing hepatocytes. So I think it's just for adults at the moment, which is a shame. But also, like gene therapy, it does make me a bit nervous doing it in children when we don't have long-term data yet.
Yeah.
But it's cool because it's a one-off infusion over 1 to 2 hours, and then it's done. Like it's an off-the-shelf kind of product. It's not like CAR T where you've got to, extract stuff, send it away, modify
Not
it.
CRISPR, is it, where they
Yeah,
go in and edit
exactly.
your DNA? It's
Exactly.
yeah.
And they say from the studies that it will probably last decades in terms of the effect. At least 3 years for most people is kind of what they say as a rough guide. But again, it must be quite hard to consent people because we don't have much data yet. And you're kind of consenting people to say, we don't know what level you'll get to. We don't know how long you'll be there for.
Yeah.
Like, it's kind of a bit of an unknown.
I guess it all comes down to the patient, doesn't it? And their
Yeah,
burden of disease. If they're coming
exactly.
in every few weeks for
Yeah,
recombinant,
yeah.
and it's ruining their lives or their,
Mm.
yeah.
hmm So, yeah, that's it, basically. It's kind of cool.
There's a little silver lining to haemophilia B.
Yeah, not if you've got an inhibitor, though.
Yeah, or you've
There
got
is
like
very limited some.
fibrosis.
Yeah.
Darn it, Harry. We were doing so
Sorry.
well.
I know. Shall we summarize our 3 golden nuggets from today?
Yeah, go for it.
I think number one is factor 9 has a longer half-life and can travel around the blood on its own and is only made in hepatocytes. So there is not a releasable pool anywhere else. So desmopressin is not an option. Number 2 is that we do recombinant factor replacement called Benefix, is the majority of treatment that you're ever going to need to administer as a hematologist most of the time. And with Benefix, remember that it's a 1-to-1 ratio of dosing, unlike the 1-to-2 ratio with factor 8 replacement. So for 1 IU per kg, it will raise your plasma factor 9 level by 1 IU per DL. So it's really neat and tidy. And maybe number 3 should be that inhibitors are less common in haemophilia B, but they can often be IgE and cause anaphylaxis, and they are not time dependent. So that can be a big problem.
And they ruin
So if you
gene
have
therapy
any
as well.
concerns about allergy in a patient who's having Benefix, you need to take that really seriously. Yeah.
Nice.
Nice. So that takes us to the end of our haemophilia section. We are still going to do lots of clotting for those of you that are enjoying our kind of methodical take through of all of the FRC path syllabus at some point before we die. It's going to take us a long time, but we will get there. But in the meantime, we're also going to start doing our new Red Cell series, aren't we, David?
Yes, I'm excited to. I'm excited by how excited you are, which is I don't know.
I've just done a 2-week Red Cell placement,
so
I'm ready to go. Yeah. So yeah, we'll start that next time. But I hope this has been helpful. And as always, if you're enjoying our podcast, please do subscribe or follow and leave a rating.
Do all those things.
It helps us. And thank you for listening.
Yeah.
Great.
Thanks for joining us.
Yeah. All right. I'll see you later.
See you next time.
Bye. Thanks again for listening to Basics to Brilliance Haematology Podcast. If you enjoy our series, please don't forget to leave a review and hit subscribe to never miss an episode. See you next time.